Good morning, and thank you very much for the opportunity to present some of the research that I have been living alongside for the past 3 years of my training. I'm a specialist registrar, for those of you who don't know me, in palliative medicine. But not so long ago, I was the renal senior house officer standing over the bed of the 97-year-old gentleman who had end-stage dementia and wondering whether he was going to die on hemodialysis that day and whether it was appropriate to actually send him down to the dialysis unit. So I came to develop an interest in this area because I did a rotational palliative care as part of my basic specialist training. And directly after that, did a rotation in nephrology in Cork University Hospital. And I'm going to start with this picture because this doesn't mean anything to you, but it might mean something to some of the nephrology nurses from Cork University Hospital, because this is the new cardio-renal tower in Cork. And I just have a memory of sitting in the Starbucks, which is, this is the view from the Starbucks of the cardio-renal tower. And I don't know if you still have 36-hour shifts in Northern Ireland, but we certainly do, unfortunately, because we're not a European Working Time Directive compliant yet. On a 36-hour shift, looking up at the third floor at where those two people are walking, at just a big queue of elderly patients sitting in wheelchairs, and one guy who's now deceased took out a wire brush and scratched his back vigorously with the wire brush. And I was saying, oh, I'm going to be bleeped to the hemodialysis unit tonight. So that's the way it was when I was in nephrology 3 years ago, and I'm sure things are moving on. Things are moving on very swiftly in the renal world in terms of supportive and palliative care for these patients. And there's been a lot of people in the audience, this is why you're here, will be aware that the epidemiology of renal impairment has changed from back in the 40s when the first hemodialysis machine was invented to back in the 60s when this article launched a female journalist's career, where she wrote a scathing article about the rationing of dialysis by age and comorbidity and social class. To the widespread availability of hemodialysis, where numbers rose exponentially from the 1970s to the 2000s. These are figures from the States. And when I developed an interest in this area, I attended a conference in Hammersmith in the UK called Supportive Care for the Renal Patient, which I very much recommend. And Professor Edwina Brown presented this painting as medical students, many doctors, and the public's perception of what hemodialysis actually does. That people enter this is Cranach's fountain of youth, and patients, patients enter the fountain looking kind of decrepit and moribund, and emerge at the other side youthful and full of life and restored to health. And we all know from our daily practice that actually dialysis doesn't restore health, and it doesn't confer a normal life expectancy. And this is more what we expect to see in the hemodialysis unit on a daily basis. And an emerging literature over the past 10 years has told us that certainly this article from the New England Journal of Medicine presented figures from 4,000 elderly nursing home residents who were initiated on hemodialysis, and at the end of year one, 58% of them had died, and only 13% of them had retained their premorbid functional status. And we also know figures from the US that the majority of patients die in hospital, in the ICU, on hemodialysis, etc. So the question, is there a role for palliative care, is no longer. There is a role for certainly generalist palliative care, and where do we start? I don't have the answers, but I'm going to share with you some of my experience from conducting research on quality of life and symptom burden in these patients in Ireland. So data from the National Renal Office in Ireland would reflect data from the US. The numbers are rising. The numbers of patients on hemodialysis in Ireland are rising. Of those with end-stage kidney disease in Ireland, the Republic of Ireland, it's about half and half. About 53% of them are lucky enough to be transplanted, and the other half will be on dialysis, whether it's home therapies or hemodialysis. And what about this third pathway? There's a lot in the literature about the third pathway. Certainly when I was in renal medicine, You didn't hear much about maximum conservative management as a treatment option. It was sort of dialysis or nothing. You've already seen these survival curves where, yes, renal replacement therapy confers a survival advantage for patients, but when you look at I'll go back. When you look at, when you adjust for comorbidity, actually that survival advantage is lost. And these are figures from Carson from a nice paper in 2009, where they looked at there being a survival advantage in terms of renal replacement therapy as opposed to maximum conservative management. But where you look, when you look at where patients spent their days, you see that hospital-free days were not significantly different between the two groups, and the days gained in terms of survival for those who were dialysed as opposed to kept on conservative care were mostly spent in hospital. So we set about examining how things were for patients back in 2011, 2012 on haemodialysis in Cork University Hospital, Kerry General Hospital and Midwestern Regional Hospital in Limerick. And we wanted to know what the symptom burden and the health-related quality of life was like for prevalent Irish haemodialysis patients at the time. That was back in 2011 and 2012. And we administered this questionnaire, the PAUSE-S renal, which was developed by Higginson's group in the UK, that examines 17 symptoms and asks the patients to say whether they experience them not at all, slightly, moderately, severely or overwhelmingly. And we also administered this validated tool, a measure of health-related quality of life that's used very, very frequently in research, that examines health-related quality of life in 5 domains and then gives the patient an index compared with population norms. And the other part of this tool asks the patient to rate their health state from 0 to 100, 100 being the best imaginable health state and 0 being the worst imaginable health state. So we have to orientate patients when we're using these tools, because of course people can get it the wrong way around and screw your results. So we looked at Cork, Limerick and Tralee originally, and I was worried that when I kind of moseyed into the dialysis unit as a palliative care doctor, that I would that people wouldn't be interested in talking to me. But it was like pushing against an open door. You know, I walked in and decided in the first centre I administered all the questionnaires myself. With the help of the renal nurses in Cork, but I spent a lot of time in the dialysis unit, and people were just absolutely delighted to be asked how they were feeling. So the response rate was, in the first 3 centres, was 90%. 203 patients took part, and they reported multiple symptoms. So arbitrarily divided by age, just picking 65 there to see if there was a difference between age groups, and there wasn't really. The majority of patients reported 6 to 10 independent symptoms. In the under 65 age group, 2% of patients said they had no symptoms at all, but that was the height of it. And in 19% in the over 65 age group, 16% in the under 65 age group reported 19 and 60% of them had 11 or more independent symptoms respectively. So what were the most frequently reported symptoms? You'll see at the bottom of the screen here, weakness, poor mobility and pain were the 3 most commonly reported symptoms. Depression and anxiety were in the middle, and the GI symptoms were up the top as the least commonly reported symptoms. Itch was somewhere in the middle as well. Now I'll show you these figures again in a minute when I talk a bit about our collaborative work. I like this question. It was just part of the EQ5D questionnaire, and I didn't really pay much attention to it, but it was in order to be included in the analysis, patients had to have completed the PAUSE-S renal, which asks them about 17 symptoms. Everybody included in the analysis filled that out, but 20% of patients left this field blank. So it was the most poorly answered question, and you'll see there that when we asked these patients who were on haemodialysis, have you ever experienced serious illness, 20% of them said, no, I've never experienced serious illness. 20% of them left it blank, and 60% of them said, yeah, actually, I have been seriously ill. So when you think of the survival figures presented by Dr. Harron, you just imagine that this is a little bit of a problem, I suppose, in terms of advanced care planning, just to make an understatement. So I was lucky enough to get involved with Dr. Fliss Murta early in this project. We decided to do the project in London and in the satellite units of King's College Hospital, and use the same tools in Ireland. And I included Beaumont in the hospital as well in the collaborative work. And we wanted to just have a large cohort and look at what Fliss calls lessons for practice. So nephrologists have a therapeutic relationship with patients that can span decades. We know that. And a lot of the literature is looking at triggers for referral to specialist palliative care. But there's another emerging literature talking about the issues that Dr. Karen Ryan was talking about earlier in terms of generalist palliative care and how patients can be supported as part of chronic disease management from diagnosis to death. So we wanted to look at the symptoms, see which ones most adversely affected health-related quality of life, so we'd know what to target on the ground to make life a little bit easier for these patients. So the final analysis, including the London hospitals, Beaumont Hospital, Kerry General, Cork University Hospital and Midwestern Regional Hospital, included 896 patients. In terms of symptom prevalence, the order of symptoms reported and the numbers of symptoms reported didn't really differ between the original Irish study and the collaborative work. And if you compare our study and the symptoms reported with studies of cancer patients and patients with COPD, we know that in terms of symptom prevalence, dialysis patients are up there. Health-related quality of life, the EQ5D summary index score allows you to compare health-related quality of life of your population with the health-related quality of life of so-called population norms. This is validated for use in the UK and Ireland, but the population norms come from the UK. So our study population of those aged 70 to 80, within our study population, the mean visual analogue score going from 0 to 100 was 58, whereas in the UK population of the same age group, their mean visual analogue scale score is 75 with a similar enough standard deviation. The EQ5D index score isn't as accessible, so I'll ignore that. So, as one would expect, total POS score, so that's your total symptom score, had a negative association with health-related quality of life. So as your pain got worse, your health-related quality of life got worse. As the mobility deteriorated, health-related quality of life scores got worse as well. And this is the order of of the prevalences of reported symptoms for the big the collaborative study with the 896 patients. So you'll see again weakness, poor mobility, and pain, the most commonly reported symptoms. Pain reported by 64% of dialysis patients. Anxiety and depression in the middle, and the GI symptoms up the top there. The least prevalent symptoms, but actually still reported by between 20 and 40% of patients. So then we did some regression analysis examining what symptoms adversely affected health-related quality of life scores. And we found that poor mobility, pain affected health-related quality of life, but the symptom that had the symptom which most adversely affected health-related quality of life scores was actually diarrhea. And we kind of writing the discussion part of this paper at the moment and thinking, why is that? Well, I suppose any of the dialysis nurses in the room could tell you that if you're sitting on a dialysis machine for 3 hours, having diarrhea is not going to enhance your quality of life and might bother you more than being constipated, for example. So did any of the anything we studied in this research positively influence health-related quality of life scores? Well, there's one thing that consistently positively influenced health-related quality of life scores, and that's being active on the transplant pool. And I think that anybody on the ground will relate to this as well. For patients who've got end-stage kidney disease, transplant is the holy grail. It's the same as remission, similar to remission for cancer patients. It's all anybody wants as far as hemodialysis patients are concerned, and I suppose the chance of transplant represents great hope for patients who have end-stage kidney disease. And I suppose I just remember administering this questionnaire to one gentleman who was taking part in the study in Cork, and him pulling up his t-shirt and saying to me, showing me a stoma bag and saying, "Come here to me." That's a Cork phrase, "Come here to me. Come here to me. Do you think a transplant would fit next to my stoma?" And me saying, well, I'll go and I'll speak to your nephrologist, I'll see if you're on the pool, etc., etc. And going to his nephrologist and saying, "This gentleman thinks that he is on the transplant pool, have you not spoken to him about the fact that he's not?" And the nephrologist saying, "Aoife, we've told him 1,000,000 times he's not on the transplant waiting list, but that is his hope, and that he will always hold out hope, no matter how many times we tell him. He will always ask, and if a new person comes along, like I did that day, he will always ask." And I always remember that anecdote. How much of the variability of EQ5D scores can be accounted for by symptom burden alone? Well, in regression, there's a thing called the R squared. Anyone who's familiar with statistics might know about it. I didn't know about it before I started this research. But the R squared for the regression model in this particular study was 21%. That means in a linear regression model, the adjusted R squared was 21%. Approximately 21% of the variability in EQ5D summary index is explained by symptom burden alone. And what that means in plain English is that a lot of what affects patients' health-related quality of life is not explained by symptom burden alone. We expected that figure to be higher. We expected symptom burden to explain health-related quality of life, poor health-related quality of life. So the rest of my talk is just going to centre around the discussion piece of this research and a few of my thoughts on the results, and a few pieces of the extra work submitted by patients who took part in my study, some of the qualitative flesh on bones piece of the research. So this is the symptom burden questionnaire, and this is at the bottom of the symptom burden questionnaire is this other section where patients were asked whether there were any other symptoms that influenced their health-related quality of life that they wanted to, or any other symptoms that they wanted to report. And in that section you'd expect one would expect patients to report symptoms because it asks any other symptoms, but actually what we got were vast pieces of prose from patients who wanted to tell their story. So this is one gentleman's story of how he felt about his dialysis journey, and he gave permission to use this, so I'm just going to read this aloud. "The following is my current view of my medical history and operations. I was diagnosed as having a high sugar level by an insurance doctor who put me on insulin and said he would need to give me dialysis. It's not edited now, otherwise I would lose both my kidneys. I was admitted to hospital for various tests. I had 7 vascular operations on my left arm to find a fistula axis, but to no avail. Instead, my head was swollen like a pumpkin. I was to have 2 further operations on my left arm to relieve the pressure on my head. Then followed an operation on my groin, which badly hemorrhaged for hours, and a special team of doctors had to be brought in. And they decided to put a graft onto my right leg, but with no success as it was located too deep. They then fitted a second graft on top of the first one, and I had serious internal bleeding. I do not have the use of my right leg as it's filled with fluid and it's like a wooden leg. They put a line in my jugular vein, right hand side, which they're using at the moment. I broke both my feet while walking to the toilet. Despite my many complaints from me, they just told me to take paracetamol. I'm still waiting for a transplant. Why is this? On a positive note, the staff have been very caring and attentive otherwise." So that's just meant as an illustration of life for a patient on hemodialysis, because it's actually, when you see it like that, it's just vastly different to what you learn from a textbook in med school, and all of those access problems are part of your daily life working in the hospital. And of course, the whole business of waiting for a transplant, I'm sure this person, like my previous patient, had been told multiple times that he's not on the transplant waiting list, but even so clung on to that hope. Actually, and speaking about sudden death in dialysis patients, when I went to find him the following Monday, he had an arrhythmia and arrested on dialysis, so that was that. What other patients contributed to the open field question? A lot of patients spoke about physical symptoms, discomfort as distinct from pain. So our symptom burden questionnaire asks about pain, and some patients filled out no for the pain question, but then volunteered that they had cramps or pins and needles or their legs felt hot at night. So, you know, a lot of patients wouldn't necessarily call that pain. So it's worth asking about that separately. Lifestyle issues, no time to spend with my kids. One lady said she dreamt about cabbage. I presume that's something to do with the diet restrictions. And then existential issues, no light at the end of the tunnel. One lady volunteered that she had trouble watching all the Golden Girls die. And the Golden Girls are a group who dialyse in a unit like this in Cork. Actually, they call themselves the Golden Girls. They've been there together for years, and they dialyse opposite each other in this kind of cosy environment, and they're the best of buddies. So I suppose it is an issue. I mean, when you hear internationally, I've heard of some efforts to have a kind of a process around bereavement in dialysis units, and obviously you don't want to confront everybody with their mortality on a daily basis, but some ritual around bereavement can be useful for some people in some settings. So how would I explain that our symptom burden doesn't account for all of the variability in EQ5D? Well, I suppose it's what we learn as palliative care physicians, that illness doesn't occur in a vacuum, that disease is end-stage kidney disease. It's the diagnosis that somebody has, but the illness is the experience of the person's disease in the unique context of their own individual life, and that health-related quality of life doesn't just comprise of symptom burden, that should be 21%, but it also comprises of kind of existential questions and emotional reactions to their particular diagnosis. So the emotional stuff, the wooden leg, the head like a pumpkin, see the words like serious, my complaints, the existential stuff, no light at the end of the tunnel, why me, and then the physical bit as well. And I like this quote from a nephrologist in renal medicine in Leicester, who said that as renal physicians, they know that from the day a patient first walks into their clinic, they're likely to have unrelenting involvement in their health care. And many physicians don't find it easy to involve themselves in the management of end of life. But for physicians familiar with rigorous intervention in complex and acute illness, the argo of success is prolongation of life. But lifelong involvement is a special privilege of the renal physician, and that one that comes with special responsibility. And I really do think that nephrologists are a special group. It's not in our gift to take over the symptom control in nephrology, because I don't even understand the etiology of pain in hemodialysis, except to say that there's a long list of things like renal osteodystrophy and calciphylaxis and access-related pain and nephrogenic systemic fibrosis, all these things that I couldn't define which cause pain in patients with hemodialysis. And this is calciphylaxis. This was one of my patients gave me permission to use this particular site. I know Dr. Haran has already spoken about this, but this is very the pain associated with calciphylaxis is very, very, very difficult to treat. And of course, in renal medicine as well, we're limited by the, we can only use certain opioids. This is a very good document that was published in Palliative Medicine on kind of exactly what types of opioids one should use in patients with renal failure. And again, an algorithm from the US looking at preferred medications to treat pain in dialysis patients. They're different from cancer patients, and we very much need to work in partnership with renal medicine physicians in treating these patients. Advanced care planning, does it extinguish hope, the hope that we previously alluded to when we were talking about the patients who volunteered to take part in my study? Well, Sarah Davison has done a lot of work, she's a nephrologist in Canada, on advanced care planning, qualitative interview studies with patients who have end-stage renal disease, and has found that actually patients have said that it would actually enhance their hope rather than diminish it to have conversations around prognosis with with their physicians. We don't have cause for concern registers in the Republic of Ireland, but I know that in Manchester and Bristol and London, over the past few years, they have developed these registers where if they feel somebody is deteriorating despite dialysis, they're automatically put on this cause for concern register and discussed at an MDT, and letters automatically go to the general practitioner to alert them. And this is just reflecting again what Dr. Ryan spoke about earlier on. The palliative care is an approach, and I believe that when this definition of palliative care was being devised, that there was a debate about whether to call it a specialty or an approach, but it was thought that calling it an approach would be the correct approach, because it's not it is not just a medical specialty. It's something that can be practiced by physicians in all walks of medicine, and it's about the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, with particular attention paid to physical, psychosocial and spiritual issues for patients. And this is the emerging literature all around generalist and specialist palliative care, and how we're moving from specialisation now back to kind of generalism again in medicine. And the idea that this old model of disease-modifying treatment, like renal replacement therapy until somebody is actively dying and then a bit of palliative care at the end, is no longer the preferred model, but rather optimal pain and symptom control should be a constant throughout somebody's disease trajectory, with maybe palliative care and quality of life and rehabilitation and multidisciplinary care coming in a little bit, at the beginning, but playing a bigger role towards the end. And disease-modifying treatment may be, diminishing as disease progresses. So back to our patients, what conclusions can we draw from my research, which is a small-scale unfunded study which I did part-time with huge help from dialysis nurses up and down the country and from our collaborators in the UK. Patients on haemodialysis in England and Ireland have a high symptom burden. They have a poor health-related quality of life when they're compared to established population norms. Some symptoms independently influence health-related quality of life more than others, but this is observational data, so you can't make any assumptions about causality here. But health-related quality of life may improve for these individuals with a so-called palliative care approach. So I wanted to finish by thanking all of the nurses in the dialysis units in Cork and Kerry, Limerick and Beaumont from the bottom of my heart, because you've been just amazing, telling me your stories and helping and handing out the questionnaires and encouraging the dialysis patients who I know you have a relationship with and who listen to you to take part in the research, and the collaborators also in the UK, the professors of renal medicine in Dublin and Cork, Professor Conlon, Professor Eustace and Dr. Plant, as well as Dr. Brian and Regina McQuillan, who have been of tremendous support to me from the palliative care world throughout this 3-year project. So thank you.